Well, good evening, everyone that's joining us for this session on perilunate and scapholunate ligament injuries. This is part of our AO Trauma Hand North America online series. So thank you very much for those attending live. I still see the number going up, so I'm just going to give it maybe another 30 seconds before we roll into it. All right, maybe I'll get started now for the introductions. We really have an amazing faculty today that has tremendous experience in treating these type of injuries. And so hopefully we can give you a little bit of practical guidance and hopefully stir up a lot of conversation on some of the controversies in managing these type of issues. We have Chuck Cassidy from Tufts. We have Kevin Malone from Case Western, and Lauren Grossman from Orland and Cohen in New York. Here are disclosures. And if this is your first time on Zoom, then I don't know where you've been for the past year. Just recall your etiquette, just stay on mute. And certainly, if you have any questions throughout this case discussion presentation, just put a question into your Q&A section, and we'll have our moderators field those questions for us. Now, the learning objectives today will be to describe the relationship of carpal anatomy and understand carpal kinematics, both in the normal and the traumatized wrist, and then really to give you a framework for how to systematically reconstruct perilunate injuries. And then we'll do a little bit of a discussion on scapholunate ligament reconstruction. If, for whatever reason, your perilunate acute treatment fails, or if you have a patient that just has a SL tear that's subacute that can be reconstructive. So again, we'll start with perilunate injuries, which will be the bulk of the conversation, and we'll hit a lot of topics that pertain also to SL repairs and then to reconstruction. All right, so I'll start off the presentation tonight with this case, true case. And I remember I came to work that day at my previous job as a level 1 trauma center. They said, hey, we're going to add this scaphoid fracture to your day today. And, I looked at these x-rays and, you're like, what's going on? Patient was transferred, had a open wrist fracture. They said, oh, inside to out, not a big deal, has a scaphoid fracture, and otherwise he's pretty healthy. And just looking at this, having treated enough of these type of carpal injuries, I knew that this was probably not quite a scaphoid fracture. So what do you think is your operative plan here for the audience? We're going to do a little bit of AR questioning. And we'll just give it a couple of seconds, and then we'll see what everyone had said. All right, Mark, can we show the results now? Okay, all right. So it was all of the above to repair everything. Well, okay. So this was the open injury, which is the so-called inside to out, and this is from the ulnar side of the wrist, which goes all the way to the carpus. And then if you look at this again, and you look at the injury films that were given to us from the outside hospital, you can see that was really a scaphoid perilunate injury. So a lot worse than what it looks like there. So we'll first start off with Lauren giving us a talk on carpal anatomy and kinematics.
Hi, so I've been charged to discuss carpal anatomy, carpal kinematics, and the mechanism of perilunate injuries. So I'm going to start off with the carpal anatomy. You can see here the osteology, the 8 carpal bones and the long bones that surround it. And you can see the inner workings between the carpal bones and how they really fit together quite well. We have the volar extrinsic ligaments, and the important ones are the radioscaphocavitate and the long radial lunate, which are the radial carpal stabilizers in green. The short radial lunate, which really just attach the lunate, which is very important, as we'll see a bit later. And then the ulnocarpal complex in yellow, which are significant for TFCCs, LT tears, and so forth. There's the dorsal extrinsic ligaments, where we have the dorsal intercarpal ligaments, which are useful for capsulodesis, and then your dorsal radiocarpal ligaments, which prevents ulnar translocation. The interosseous ligaments, which we kind of already touched upon, are your scapholunate interosseous ligament, which is important here, and your lunatrocretial interosseous ligament in yellow. What's important to note of the two is they kind of are a bit opposite, where you have your scapholunate, which has been shown that the dorsal part of it is the strongest, most important portion of it, whereas in your LT, the palmar fibers tend to be stronger and most important. And recent studies have kind of alluded to the fact that maybe that's not 100% true, or we may need to repair more than just your dorsal ligaments on your SL and so forth. So carpal kinematics, there are multiple theories out there, and there was the row theory, which basically talked about your distal row, your proximal row, and your scaphoid, which was your connecting row. And then there's the column theory with your radial, central, and ulnar columns, which recently have kind of been shown that they're not quite adequate. So there's 3D theories, and there's still more theories which are coming out as we continue to have more research on the carpus. So this theory really focuses on the proximal row, as the distal row is quite tightly bound by ligaments. And what they found is that flexion and extension are really consistent at about 60 degrees. So when you flex your wrist at 60 degrees, your scaphoid flexes 70% of your capitate and your lunate 45% of your capitate. And in extension, your scaphoid and capitate extend the same amount, but your lunate only extends about 65% of the capitate. And this just shows how these bones and ligaments and everything else are quite interconnected, and it's quite complex. So we'll move to the dart thrower's motion, which is really significant for the most part, a lot of rehabbing, especially in this specific situation. So dart thrower's motion is radial extension to ulnar flexion. And what's notable is that the proximal row doesn't move significantly. And that's very helpful in rehabbing any of these type of ligament repairs. So we'll get to the more interesting portion of the talk, where perilunate dislocations. You can see here on the right, we've got a dorsal perilunate dislocation. So they're usually high energy injuries, and it could either be just ligamentous injury, it could be bony and ligamentous. They tend a lot of the time to be underdiagnosed, and a lot of times they end up being missed, whether it's in the office or in the emergency room. They're quite challenging to treat because they have so many different injuries within one injury, meaning multiple ligaments or carpal bone fractures. And the outcomes historically are quite poor because of the injury, fixing the injury, and then the stability of the wrist and gaining the motion, where a lot of times patients end up being quite stiff. What's really important to note is once you see this and recognize this injury, a prompt reduction is the most important thing to do. And then as soon as possible, performing the surgery for more favorable results. So with perilunate instability, there's a dissociation of your lunate from the carpus, which includes both perilunate injuries and lunate dislocations and fracture dislocations. As you can see here on the right, there's a scaphoid fracture. There's a scaphoid fracture, and you can see that the lunate kind of looks a little bit weird and it looks off, as there are not normal carpal arcs here. So there's a disruption of both intrinsic and extrinsic ligaments, which I went over earlier. And despite looking at this x-ray and seeing what's going on here, a lot of times they're subtle and they're missed on initial presentation. So here's a Mayfield classification of the perilunate dislocation. You can see it goes in a circle, where stage 1 is your scapholunate dissociation, and then it goes around to the lunocapitate dislocation, to the lunotriquetral dislocation, and then the whole carpus separates from the lunate, as we saw on the prior x-ray. And then stage 4, your lunate dislocates from the radial fossa, and that's where the short radial lunate comes into play, is that's the only thing that's really holding that lunate in place, or not in place, but holding it in the carpus. So here we start with stage 1. Here's some x-rays and schematics, which are helpful here. You can see there's a SL injury. You've got a diastasis or scaphoid malrotation. You can see here it just doesn't look quite right. And the scaphoid is not quite aligned with the lunate. And here we have 2 where you have the dorsal dislocation of the capitate. You can see there's quite a large diastasis on this x-ray here between the lunate and the capitate. And again, once you can see that scaphoid and the lunate really are not lining up. And here's 3 where you can have a LT injury. Here there's a fracture of the triquetrum. And you can see pretty much the whole carpus is not attached to the lunate and the radius. And then here we finally have stage 4 where your lunate is dislocated volarly. So there are 2 different types of patterns of perilunate injury. There's the lesser arc injury, where we see here with this yellow line, where it's a purely ligamentous disruption. Your SL, your capitate dislocates from your lunate, and you have an LT injury. And then there are greater arc injuries, which include transosseous pass and at least 1 carpal bone. So you can have a transradial, perilunate, transscaphoid, and so forth. You can have ulnar styloid fractures as well, so those are things to keep in mind. But what's interesting is that the transscaphoid variant is the most common. So here's a little schematic where on the left is what I just showed on the x-ray, but here we have on the right showing all the different types of fractures. But what I find quite interesting on this is that when you have a capitate fracture with the perilunate dislocation, the proximal pole of the capitate head rotates 180 degrees, as you can see here by the star in the middle. So x-ray is the most important for diagnosis. You don't need necessarily further imaging, although it can be helpful for preoperative planning. On the left here, we see a perilunate dislocation. You can see the carpus just doesn't look quite right. Things are a bit jumbled. Your scaphoid's sitting on your radius. It's not really lining up with the rest of the carpal bones, and you don't see normal joint lines. And on the right side, you see the normal wrist. What's important to note is that you need to look for your carpal arcs. So if you look at an x-ray, as we see here on the left, so here there's the proximal carpal arc, where you could see it's starting on your proximal pole of the scaphoid, outlining your proximal pole of the lunate, going through the ulnar aspect of the wrist, and then your distal arc, which is on the ulnar aspect of the scaphoid, curving around the capitate through the hamate. And you can see here on the left, they're disrupted, and you can't really make any of it out. So again, what's important on these x-ray finding are the disruption of the carpal arcs. You have overlapping of the carpal bones, as you can see here on the upper right-hand corner. There's crowded and jumbled carpals, and then there is a foreshortened carpus. As you can see here, you lost your arc, you lost everything, it's shortened. And what's interesting is that your lunate also can look triangular. So something looks off here, your lunate's triangular. That pretty much is telling you there's something going on here, most likely a perilunate dislocation with the way that this lunate looks. And then, of course, you're looking for your greater arc fractures. As you can see, there's this scaphoid fracture. So here's an x-ray of a normal wrist. When you're first looking at it, you need to make sure that your scaphoid is overlapping your pisiform. If you see your pisiform separate, you know that's not a good lateral, and so that's not overly helpful in your x-rays. But this is showing that your capitate sits pretty much on top of your lunate and your scaphoid, and they all overlap each other, really sitting directly over the radius and in line with the third metacarpal. So again, these are frequently missed injuries, and the transscaphoid is most common variant. And what's important to note is a carpal tunnel. So if you have associated carpal tunnel in something that hasn't been reduced, it's something that can be reduced. You see if the carpal tunnel gets a bit better, and then you determine, you know, sometimes it's emergency. If carpal tunnel doesn't go away, that's definitely, in my eyes, an emergency. But also, if you have a scaphoid fracture with a patient with carpal tunnel, you should really be thinking that there's something else going on. It's not just a scaphoid, you know, it's not just a scaphoid fracture. Most likely there's something else going on, because it's not quite that common to have carpal tunnel with your scaphoid fracture. Here's a picture of a transscaphoid transcapitate. So as we're talking about or showing you earlier, the capitate is rotated here 180 degrees, and you see the scaphoid fracture, and you could see here the capitate fracture. It's a little bit more challenging to see on the lateral here, but right over here is your capitate fracture. And here on the lateral, again, the x-ray is the lateral x-ray is critical. So you see here the carpus is completely dislocated from the radius and the lunate dorsally. So again, you see the loss of the collinearity between the radius, the lunate, and the capitate, which was in that prior x-ray. And in your perilunate injury, your capitate is dorsally displaced, as you see right here. And then there's a lunate dislocation, which is really stage 4, where your lunate dislocates volarly into the carpal tunnel. And we see here the same. On the right side, you have a perilunate dislocation. The capitate and the rest of the carpus is dorsally dislocated from the lunate and the radius. And we have here on the left-hand side, a lunate dislocation. So the capitate and everything else is lined up with your radius, but the lunate itself is just volarly displaced. And this is also known as a spilled teacup sign. So hopefully all these things can help you with your diagnosing of everything.
Great, thanks, Lauren. Can you guys see that in full screen?
Yes.
Okay, perfect. Sorry. We switched to Office 365, so I'm learning this here. What Lauren talked about, I think is quite helpful as we figure out how these injuries happen, and then also plays into what things you can expect. So that first case, which was a transscaphoid perilunate injury, I think a lot of people said you'd fix everything, including the SL. Typically, now I've seen variations of this, but typically for a transscaphoid, the SL is typically intact. And so in that one, it would be the scaphoid, fixing the scaphoid and the LT in that transscaphoid greater arc type of injury. So let's talk about this case. It's a patient who fell from a pretty high height off of a ladder. Wrist pain only, some paresthesias in the median nerve distribution, no breaks in the skin, tender at the snuff box, and slightly longer or greater static two-pointer discrimination, but intact in the median nerve distribution. Otherwise, the perfusion is just fine, and you get these X-rays here. So I'm just curious then, how would you reduce this? Let's say you're at home and you get called by your resident or your fellow, or maybe you're doing it on your own. How would you anesthetize this and do your reduction maneuver? And while the audience is answering this, Chuck, do you have any thoughts on what you would recommend if your fellow called you and said, "Hey, I got this perilunate, I don't know if I can get it reduced"?
Well, I would reassure him that if the scaphoid's broken, it's usually a little easier to reduce, actually. So stay calm and just reduce it. So this is done at our hospital by the residents typically, and they will get sedation and finger trap traction. They'll hang around for a little while with a counterweight and get it to relax. And then, you want me to talk about the reduction maneuver or not?
That's a perfect segue.
Okay. By me? Okay.
Yeah.
So the one thing you don't want to do is convert a perilunate to a lunate dislocation. So definitely maintain some pressure. And I would be expedient because of the altered sensibility. So this is something that should not wait. And then some dorsally directed pressure over the lunate just to make sure that it doesn't pop out into the carpal tunnel. And typically hyperextension, traction hyperextension, and pop it back in.
Perfect. Thanks, Chuck. Yeah, I agree. I think the difficulty I think people have with reducing these is not getting the patient relaxed enough. Doesn't mean they have to go under general, but I think getting enough sedation so they're relaxed, and then letting you actually do this reduction maneuver that I think is fairly universal, a good way to try to get this reduced in an enclosed manner. And then how about would you, in this setting, so this is after we got the reduction, would you get any additional imaging studies? The audience, I'm going to have you answer that question. And then while you're answering that, Kevin, in this case here, it's a transscaphoid perilunate. You got it reduced. Is there any utility in getting MR, CT, or anything like that in this patient who has a little bit, not an acute carpal tunnel syndrome, but definitely took a little bit of a ding?
I'm not sure that there's much role in advanced imaging in my practice. This is an injury that's going to require an open exposure. You're going to have your own eyes on the important structures here. And so I'm not sure that adding an MRI or a CT scan is really going to add much to your knowledge and make any difference or impact on your planning for this procedure.
Got it. Thank you. Let's see what everyone said here. Yeah. So a lot of people said CT scan, and I think unless it's emergent, I think it's probably of all of those, CT scan is something that I think is something you could consider. If you want to say, look at the scaphoid, for instance, and decide that I can go volar or dorsal, or, if you're concerned there's a transcapitate or an associated carpal fracture that you may need to fix, I think it's reasonable if you have time on your side. And in this case, I did get a scaphoid. I think we reduced him. And then it wasn't an emergent case, and the CT scan just helped me realize, it's more kind of in the waist or distal waist, and I could go either way, volar or dorsal. But it was helpful, not necessary, but it's something that you could consider. But let's
Peter,
say, yeah,
can I interrupt for just 1 second?
yes,
I would
please.
say some of the most complex scaphoid fractures I've ever seen are in transscaphoid perilunate. The obliquity is sometimes crazy. They may be comminuted. I personally think it's helpful to get them. Although, like Kevin said, you're seeing it, but I think to me it's a little bit easier for me in planning to have a CT if there's time.
Yeah, it just helps you prepared.
This is Jesse, we found in our study a fair incidence of chondral injuries, cartilage flakes, and also, as was described, more displacement than you think, and occult fractures that you didn't believe. So a CT, these are big injuries, so CT scan I think is very helpful.
Yeah, thank you for your insights, Dr. Jupiter. I agree. I think if you can, I've never been upset, I should say. I've never been upset I got a CT scan. I think it's always been helpful in my planning. So let's say this patient who has kind of some median nerve symptoms, you got him reduced. What do you think the timing is for this type of surgery? Because if you're at an academic center and you have a really eager fellow and they want to do it while they're on call, you can justify it. But how about in the real world where you're the person reducing this? When would you fix this, Lauren? If you're busy in practice in New York and you got it reduced, when would you take this to the OR?
So I think that if the patient didn't have median nerve symptoms and they went away, I would want to take it within the next few days to the operating room. At most a week, but probably sooner. If the patient had carpal tunnel symptoms and they didn't go away, I would take them pretty much with, if it's 2 a.m, maybe I'll take it at 6 a.m. But other than that, I would take it pretty much right away.
Got it. Yep. If they have an acute carpal tunnel syndrome, yeah, you definitely, I think it's probably prudent to take that as soon as possible. And if it's that close to daylight hours, maybe wait for the varsity team to show up to help you out. Any thoughts from the rest of the panelists? 'Cause I know this is a question, you have when, you're not sure when to take them. And I think it's very reasonable to take them within the next couple of days in this situation.
I think if you have, Jesse, if you have pain out of proportion after you reduce the injury, that's a median nerve injury. And if you've given them sedation, the sensibility may be a little off, but pain out of proportion, think of the median nerve.
Absolutely. Okay, so in this patient here, I guess the first question is, would you reconstruct in this young patient with this transcaphoid perilunate, or would you go straight to a salvage because maybe that seems more reliable? If you can get them to heal like a limited risk fusion, or you could just take the distal pole out, or what are your thoughts on what you would do at this point? And while the audience is answering that, Kevin, what are your thoughts on the initial question of, do you reconstruct it or do some sort of salvage procedure?
Well, I can't remember the age and demographics of these type of this particular case, but in most of these cases, we are going to attempt to repair all of these things primarily. Timing wise, I agree with the statements made previously, but fixation of the scaphoid and then evaluation of the soft tissue injuries, you got to imagine that there's a lunotriquetral soft tissue component. Oftentimes, typically we would expect the scapholunate ligament to be intact with this scaphoid fracture, but there can be situations where the scapholunate ligament is also injured. So you want to evaluate that and repair, reinforce if needed.
Yep. No, I agree. I think, and this was a younger patient. He was like in his early 20s. And I think if I can reconstruct it, I would always try to do that. And maybe our more respected senior panelist faculty may have any differing thoughts. I remember I was talking about this one time at a meeting, and someone that I respect tremendously had said, I've noticed that the outcomes are not the best. And so not saying that they did it, but they said, should we think about just going straight to a four-corner fusion or a PRC? And, I thought it was a little excessive, but, or aggressive, I guess. But maybe any thoughts from our more senior faculty? Would anyone have a role for going straight to some sort of salvage because the results may not be the greatest with these?
I'll speak up. The results are not the greatest with a four-corner fusion or a PRC either. You're not going to get a normal wrist with any of those options.
I think some of the best
salvageable, fix it.
Some of the best studies from Hertzberg and others, 15-year average follow-up, there will be some deterioration of function, and a lot has to do with chondral injuries, but much better than salvage, especially in this young person. So I don't think there's much role for that.
Peter,
Yep.
can I just make a comment? Terry,
Yeah, Terry, please. Yeah.
Yeah. If you've got a scaphoid fracture, which you have here, it's much more reliable for the acute repair, because you're not relying solely on soft tissue ligaments to heal. You've got a nicely reduced scaphoid, you've got bone-to-bone contact. So as that scaphoid heals, and pretty much these always heal if they're reduced nearly anatomically and stably fixed, you've reestablished your proximal to distal pole linkage. And so the results are, barring what Jesse said about the chondral injury, which I agree with, the results are way better for this injury than, say, a pure perilunate. The pure perilunate injuries, which are only soft tissue, those are a whole other story. In my opinion, and at least in my experience with them, maybe I'm not doing them right, but I've had real trouble keeping them reduced for the long term, where it's purely a ligamentous problem. So I would personally, I would never do anything other than fixing the scaphoid, pinning the LT, and whatever else needs to be done in this injury. But in a perilunate, only soft tissue injury, I would think about something else in an older person. And that's where you might consider that a lower demand person may be doing something like a PRC in that age group. So what's older, we can get into a debate about that. But
No, got it. No, I think that's a great point. Thank you for mentioning that. With a transcaphoid, that critical SL is usually intact, so you have that going for you. Probably the biggest
point. This is Rob Wysocki. One point just that Terry brought up, where some of us seem to differ. He brought up fix the scaphoid and pin the LT. Others have talked about LT repair. I guess I would wonder for the other panelists, how often do you find yourself fixing an LT ligament in this case? And are you just doing it dorsal through your dorsal exposure? Or are you, for all of these, doing an extended carpal tunnel approach and fixing that more robust and stout volar LT? I kind of think of there as almost being three options. Just kind of fix the scaphoid and pin the LT reduced versus some sort of dorsal soft tissue repair or volar soft tissue repair.
Actually, Rob, we're thinking in the same logic here, because that's the next slide, which is basically, if you're going to reconstruct, which I think most of the panelists agree that you would reconstruct, what would be your approach? Which kind of leads into your question, Rob. Maybe we'll launch this poll. This is probably, I think, the area of most controversy, in addition to the next question I'll have, is which way do you go, dorsal, volar, or both? Maybe Kevin, do you have any thoughts on dorsal, volar, both, or case-based?
So, I think you take each one of these individually. I don't think you're going to make any broad strokes here saying you're going to treat all of these type of injuries in the same way. If the patient has carpal tunnel syndrome and then you're committed to do a volar decompression of your carpal tunnel, and then you have access to the the volar carpus and the floor of the carpal tunnel, and you can address whatever you need to do. But in the apps, or if there is an unreducible volar lunate dislocation, same thing. You have to make some form of volar exposure here. But I'll say in my experience, and I certainly don't have the same experience as some of the other members on this panel, a majority of these, like the case that you've just presented, in the absence of carpal tunnel syndrome, I try to do a dorsal only approach. These patients are going to get, super stiff anyway. And I think if I can approach from just one side of the wrist as opposed to both, perhaps we can, preserve some degree of sagittal plane motion for the wrist and not lock them up completely, just for postoperative scarring.
Got it.
Peter, if I might add, one thing that wasn't on the choices is an arthroscopic approach. There's a large advantage. It helps you debride the joint, wash it out, and you can fix the scaphoid percutaneously. And the lunotriquetral and all of I think one of the problems is that we use pins, K-wires, and K-wires don't tend to last the length of ligament healing. And so I found putting a compression screw, a headless screw or a headed screw across the LT allows you to have much more security and a better healing potential. And you can do that all arthroscopically.
Hey, Doug Hamill here. Maybe I'm oversimplifying this, but if I have a patient that has median nerve symptoms, I will do a carpal tunnel exposure. And I think that closing down the space of Poirier between the proximal and distal rolls actually helps stabilize the scaphoid. And if you've tried to stabilize the scaphoid without doing that, the scaphoid is all over the place. But if you close down the space of Poirier with sutures, not necessarily wires, it really makes the reduction of the scaphoid a lot easier. And then I go dorsal and I expose the fracture from dorsal and we'll put a compression screw across.
Yeah, those are great points, Dr. Hannell. Yeah, I think that you can see the audience out there that there's there's logic behind all the different approaches, and like Kevin alluded to, the volar approach, there's a concern that you add more flexor tendon adhesions. The dorsal is, I think, probably the utilitarian way, unless you're doing arthroscopic, and then combined, there's always a concern for increasing stiffness because you're going, not 360, but on both sides of the carpus. So I think it's still probably whatever works best in your hands that you can get a good anatomic reduction is probably the answer with whatever means that you do. And then in terms of this, the scaphoid, how would you fix this then? Yeah, if let's say you're just doing all dorsal approach, would you do Hellas compression screw, K-wire? There's not too much comminution, but there's, I think with most all scaphoid fractures, a little bit of dorsal comminution. Any thoughts here? I'm just going to see what the audience says. Chuck, in this situation, that's kind of more waist, distal waist, would you use a Hellas compression screw, where sometimes I worry if it's not on the right spot here with comminution, you may kind of crunch it down or lose a little bit of your scaphoid geometry?
Yeah, this is where CT is helpful, I think, for this one. It looks as though, I'd like to scroll through the images, but you could go either way. And I think it's important to differentiate a volar approach to the scaphoid from a volar approach to fix a perilunate.
Yes.
So it's not the same approach. I think you go either way. If you use a screw with a continuously differential pitch, for example, you're not going to over compress it. You want to make sure that it's not gapped, though, because it may not actually oppose if there is a gap, because it's like a gear and it's going to bring the fragments together. If they're gapped significantly, it won't accomplish that. So it's very important to get the reduction before you put the screw in. I like to go dorsally, for the rest of the perilunate anyway. So I would probably go dorsally and see if I could see the fracture from that approach. I would probably fix it from a dorsal approach.
Okay. All right. And then the question about the carpal tunnel release. So in this patient here, I guess, who had a patient who does not have acute carpal tunnel syndrome, non-progressive, but still had some issues here. What would be your reasoning to do a carpal tunnel release in these patients? And as the audience is answering, maybe Lauren, when would you add a carpal tunnel release? Only if they have symptoms, certainly if it's urgent or acute carpal tunnel syndrome, like you mentioned before, or never. Just assume that it's nepraxic and it'll get better, or always.
So if there are any median nerve symptoms, whether or not it's neuropraxia, carpal tunnel, I'm going to do a carpal tunnel release. And sometimes, depending upon the acuity and the swelling and whatnot, sometimes I'll just perform a carpal tunnel release almost prophylactically. I'm going to say usually within the first few days of doing it, I would just do a carpal tunnel release, because if for some reason the patient potentially could develop carpal tunnel after fixing, I would hate to take that patient back. If I'm doing it and it ends up being one of those delayed presentations, patient doesn't have carpal tunnel, and it's, a few weeks out after the injury, then maybe I might not do it. But most of the time I probably would.
Okay. And then Rob asked this question about, do you repair the volar, LT, and or SL? And Dr. Hannell's point about putting a stitch through the space of Poirier, I think that is helpful. I know that there's concern that if you do that, you may limit their midcarpal motion if it scars and you imbricate it and things like that. But I do think it's helpful. I'm curious, maybe Chuck, you'll get into this in your talk, so I won't ask you, but Kevin, I think from your response, you wouldn't always go volar, so then you would just fix the dorsal LT then?
There's not really a lot of LT material dorsal to fix in a lot of these. So in most cases, I'm pinning it. or putting a screw across, as Dr. Jupiter suggested. That requires oftentimes then a second trip to the operating room to remove that screw. But if I'm going volarly, then I agree with Dr. Hannell, and tightening up, closing up that space of Poirier is my go-to there.
Okay, very good. Okay, well then, now that we've talked about those things, it looks like the audience was almost 50% on both volar, SL, and LT. We'll get some pearls, tips, and tricks from Dr. Cassidy.
Thanks. Just some comments from the peanut gallery that I'd like to share. We spent a lot of time talking about the radial side of the wrist and the scaphoid, but the ulnar side of the wrist is an issue. And Tom Fisher brought up that a CT scan is very helpful in assessing triquetral fractures that may be associated with perilunates and the orientation of the fracture and how to fix it. Okay, so level 5. So there's been a lot of discussion, and I want to bring up Jesse's point, which is an interesting one. There's a paper, I believe it was from Singapore, used on arthroscopic reduction and pin fixation of perilunates with outstanding results. That's with no ligament repair. That's just cleaning the joint out, reducing it anatomically, and pinning it. The second is that late LT instability was identified by Lichtman, and back in the day, the LT interval was not pinned. So it's the pinning more so than the ligament repair. That's the important thing. So goal number 1, anatomic reduction. 2, stable internal fixation. 3, actual ligament repair is less important, but I do repair the SL. Proper pin placement is critical when you are addressing these. You got to be strategic. And so in this instance, the pins that you see there are bad pins. The pin over the radius is going to impinge on the radius and cause some soft tissue irritation and may migrate. The pin more distally is going to irritate the extensor tendons, and they're going to pus out. And then the third is you never want to penetrate the subchondral plate because these pins can migrate and scuff up the radius. So my ideal pin configuration is this Scapholunate. That's a type of Capitolunate, Scaphocapitate, and Triquetrolunate. So this is, to me, an ideal pin configuration, as you see here. And I like the triangle. I think the triangle makes it more stable. And on the lateral, you want the Scapholunate interval reduced, the Lunocapitate interval reduced. And as I was preparing this talk, this was sort of my ideal pinning. And then I looked and I realized that the LT is not quite right. So it's kind of funny because I was using this as an example for years. It's not, the LT joint is not totally reduced there. If you have a lunate dislocation, pre-reduction makes for a safer approach. If you need to go volar, the carpal tunnel is distorted by the lunate. You have to be very careful that you don't damage the median nerve. So start proximally in the distal antebrachial fascia and work proximal to distal and protect the median nerve as you're exposing it. Okay, but in general, I like to go dorsal because the view is better, the reduction is easier. You can fix the scaphoid, and you can fix the scapholunate. I go volar if there's an irreducible lunate dislocation. If with carpal tunnel syndrome, again, the carpal tunnel is distorted, and then I fix the capsule while I'm there. But otherwise, I don't routinely go volarly. Those would be my indications to go volar. Irreducible carpal tunnel. This is a cadaver. I'll just go through the steps. So for a dorsal approach, a dorsal longitudinal incision, think maybe this patient will need a wrist fusion in the future. Put it in a place where you could fuse the wrist later. I go through the third compartment, as you see there, extend into the second compartment, and then dissect off the radius. Here, this is a cadaver. You can see the dorsal radiotriquetral ligament intact, but usually that's been disrupted by this injury. You can see the scapholunate injury and the capitate. As Jesse mentioned, there are often osteochondral fragments, and you can see here the head of the capitate has lost articular cartilage, and I inspect the joint document in my op note and debride. Okay, then my next step is while the perilunate is still dislocated, I place a 0.062 inch K wire from the capitate into now through the second intermetacarpal space. So this is kind of something I learned from rheumatoid wrist fusion surgery from my mentors. You have to make sure that it's a little bit ulnar. If it's radial, it's going to end up in the capitate. If it's radial, it's going to end up in the scapholunate interval. So you want to have it that way. And then I withdraw it, as you see here. So it's coming out the second intermetacarpal space. You want to make sure it's going to line up well and not be in the scapholunate interval. And then I take a look, and it's interesting. Usually with isolated scapholunate tears, the scapholunate ligament ruptures on the scaphoid side, and you reattach it to the scaphoid. Oftentimes with perilunate injuries, it's either a mid-substance or sometimes off of the lunate, actually, kind of backwards. So the next step for me is to take a look and see, because the real estate market is tight, to see if I'm going to use anchors, where they're going to go. And I like to place the anchors first, because you can pass a pin through around an anchor, but you can't pass an anchor in a place where the pin has already been placed. Okay, so I put the anchors in. And then for me, it's a little bit of a Rubik's Cube. So you can either reduce the scaphoid and lunate first, or reduce the capitate and lunate first. But it all has to sort of go together. So next is be strategic about the joysticks. You want to put some joysticks in that are fairly stout that you can control the scapholunate interval with, but put them in a place where they're not going to be in the way when you place your pins. So next step is I cheat. So this pin is placed percutaneously, and then I place it superficial to the scaphoid so I can see the trajectory. You don't need a C-arm. You're distal to the styloid. Make sure it's going at the right angle before I have the resident or fellow drill it. So the next step is, like I said, either reduce the scapholunate or the capitolunate first. And I used to do capitolunate first, but oftentimes the scapholunate doesn't reduce properly if you do that. So I put the scapholunate pin in first, and then advance the capitolunate pin. Then you got to look critically. Okay, so looking critically here, it looks pretty good in terms of the gap, but to me, if you look here, that doesn't look quite right. That's a little bit of a V. It shouldn't look like that, and this is what it looks like if you look a little more volar. So the proximal row, the bones are rotated with respect to each other. Okay, so it's important to keep that in mind. If you use straight pins, it's hard to control them. So what I like to do is bend the pins. You could get a little bit more of a 3D kind of control of the pins. A clamp is helpful, although again, you can gap on the volar side if you over tighten it. So you got to be careful about that. There are some sleeves that you can use as a clamp to place over pins. We don't have them. But here's a better reduction. You can see there, the gap is reduced. The lines are parallel. You can see, and that looks good on the left-hand side. So then I put the capitolunate pin in, so that construct is relatively stable, although, as Jesse mentioned, it could still slide with K-wire, so you got to be careful. Then I put a scaphocapitate pin in. Remember that the distal pole is more volar, so that you're going to end up distal to the styloid, and it's going to be a little bit more volar. I put that in percutaneously as well. And then an LT pin, and I do the same thing. I cheat, so I place the pin so I can see it under direct vision, and reduce the LT interval and advance the pin that way. So then I'll remove the joysticks. The other thing is I usually these days I will put a second K-wire from the scaphoid into the lunate if I'm using pins rather than a screw, because it can still gap with just one pin, even if you have a scaphocapitate pin. So, and I try to make them so they're not totally parallel, as you see here. Okay, then remove the joysticks and repair using the pre-placed anchors. You can use the dorsal intercarpal ligament if it's not ruptured to augment the dorsal scapholunate ligament fibers. So I don't go volar, just dorsal there. Final product, look critically, make sure everything lines up. Cut the K-wires deeper than you think. I haven't had any problems with the radial sensory nerve putting them in percutaneously. It's harder getting them out. On the ulnar side of the wrist, if you cut them just under the skin, they always bother people. They end up eroding through the skin. You have to cut them deep. I think of it as a Lisfranc injury. Don't think of it like a distal radius fracture. This takes a long time to heal. And so I say 8 to 10 weeks during a cast. I take them back to the OR to take their pins out. Remember, there are often associated injuries, as Lauren mentioned, and if you ever see a scaphoid fracture with an ulnar styloid fracture, think that this is a transscaphoid perilunate variant like this one here. I like this just because it illustrates the injury all across the wrist, like one of Lauren's examples. Here was a styloid with a soft tissue injury, and you could see that the styloid is very comminuted. And I used an external fixator to protect it because of the soft tissue injury. And I'll conclude with this one. This is a who knows one. And oftentimes, I would never get a CT scan beforehand. I'd like to get this thing reduced. But so here's one. It just looks kind of crazy. You could see that there's definitely a perilunate dislocation component to it. And it's reduced. And now we can see this ulnar styloid fracture. You can see that there is a scaphoid fracture, but the proximal pole of the scaphoid is not oriented properly, and it's not completely reduced. So here's a re-reduction in the emergency department with a cast on, and you can see that you knew that there was a scaphoid fracture, but now you also see a scapholunate ligament tear. And believe it or not, it can happen. It's not that common. It's interesting to think about conceptually. If the scaphoid breaks, the scapholunate ligament will never tear. But if the scapholunate tears first, you could get a scaphoid fracture. And here's the intraoperative. You could see the scaphoid. I like this illustration because you could see the osteochondral injury on the capitate, and the dorsal scapholunate ligament fibers can double in size before they rupture. So it can lengthen 100% before it fails. So it can be functionally incompetent, but actually the fibers look like they're intact, as you see here. You can see the gapping. And here you have to be very strategic again with your pin placement. So you want to use a smaller screw in the scaphoid so you have room to put pins in. And then just in that instance, just imbricate the scapholunate and it'll always gap a little bit. So in summary, it's like a Rubik's Cube. Be strategic. Anatomic reduction is critical. Stable pin placement, avoid pin problems. Make sure you cut them deep enough. Because if the pins erode through the skin, it's a bad problem, especially if it happens early. Critically assess the radiographs during each step. And I always, before the surgery, hang some crepe. A stiff but stable and relatively pain-free wrist is a win. Thanks.
Thanks, Chuck. That was awesome. That was awesome. A lot of sage wisdom there. Let me pull this up. So pretty much exactly how Chuck said, I fixed this this transscaphoid perilunate, and I was dorsal, so I decided to use the dorsal approach for antegrade headless compression screw, and because of the comminution, I left that pin in there as an anti-rotation kind of strut pin, and almost always for any scaphoid waist or proximal fractures, I'll put a SC pin across. Some of the commentary amongst the panelists was putting in so many pins, and you can see here I used to put parallel pins in across the SL and the LT, but then I stopped to just going to one pin because I think the theoretical anti-rotation parallel pins, I think it's probably not that much, in my opinion, and the aggravation you get in the OR, having your team trying to put these parallel pins, it was just too much for me. So I started doing that, and then here's this young man 6 months out, certainly stiff, but like Chuck said, I always lay crepe, saying that these are bad injuries, and we'll just get it reconstructed, anatomic, and then we'll try to work on motion. There's a couple of things about perillunates that Chuck mentioned a little bit, in the sense that sometimes the SL or even the LT, it just doesn't have enough substance. You try to pull it down with your suture anchor, but it's just tearing through. There's nothing there. What do you do in that situation? And I think, at least for me, and I'm curious what the other panelists do, either, I do the ligament sparing capsulotomy, and if I can't grab it very well, I'll just use the proximal portion of the DIC just to serve as a soft tissue augment for repair, or even just add on the capsulodesis du jour that you like. Or if you can't do that, a lot of times I'll just, prepare the surface, put my suture anchors down, and then just grab the capsule on top, and you're reconstructing the now recognized dorsal capsular scapholunate septum. But I think if there's nothing else there, these are the things that I've done. I don't know if any of the other faculty members have any other pearls.
I would say I like your
Okay.
illustration of the dorsal intercarpal ligament. If it's intact, that last image, it's like a bucket handle. So you keep it intact on both sides, and you just drape it across. And if you put an anchor in each one, you can tack it down. I like that.
Yeah, and a lot of times when I put those sutures anchors in, and I feel like I could grab some SLLT, I'll just leave those tails long, and then and pull it through the capsule as well. And I just wanted to mention, I'm so glad, Chuck, you had that case about kind of a challenging dogma. I think human injuries can challenge dogma that, I said transscaphoid perillunates typically don't involve SL injuries, but you've seen that. And like Lauren mentioned, typically in perillunates or lunate dislocation, the short radiolunate should be intact. But in that patient here, so I'll just show you again, this greater arc injury. Here's from dorsal, fingertips to the right. You can see that lunate is completely rotated, and in that case, the lunate is completely stripped of everything. And in that case, you have to repair that your volar extrinsic ligaments down. And I had seen enough of these in my practice when I was in the military that we looked at my cases throughout my military career. This is how I fixed it with the suture anchors. Here I use the all suture anchors here, and I ran out of those, so I used this metal suture anchor for the dorsal capsule. But we looked at the 27 that I treated over this 4-year period, and I always go volar, so I could look at these 8 of those actually had a short radiolunate injury. And I hate showing my own study. I don't mean to, other than the fact that this is something that was like, I was like, this can't happen. Mayfield never said this happened, but it can. So just recognize that there's so many different variants. You just have to recognize all the critical structures that need to be repaired. I'm going to close that section out. We have 30 more minutes, and it just adds on to our perilunate carpal instability talk, which is subacute SL injuries. Now let's think about this patient. He's 43 years old, very active, was playing basketball and fell, dorsal midline pain about 2 months ago. Has a scaphoid shift test, tenderness at the SL, LT's okay, neurovascularly intact. And you could see this image here, which something just doesn't quite look right. And just like Lauren said, if you look at Galula's arcs, Galula's lines, they just don't quite fit. And this patient came to me with an MR, which was quite revealing. You can see the proximal pole is now subluxating out dorsally. You can see that big space here between the SL. So clear, full dorsal volar membranous SL tear, and enough now at 2 months with enough of the secondary stabilizers to cause this DC instability pattern. So let's poll everyone here. What would you do in this case 2 months out from this SL tear? Oh, sorry, Mark, if you can go to question 11. Sorry, I took some out for interest of time. So maybe while you guys are answering that, I know Kevin is going to talk to us about how he reconstruct these. Lauren, for something like this, what would be your approach for either fixing it, repairing it, reconstructing it, doing a, like Dr. Jupiter mentioned on the LT, kind of like a reduction assisted association?
So I definitely don't do it arthroscopically, but I definitely give my hat to those who can do it. But normally I'll do, say, a dorsal approach, and I usually look at the ligament. It's 2 months out, which is kind of long. Usually 6 weeks ends up being your cutoff. But if I felt like the ligament was in decent enough shape, I might consider repair. If not, I would be prepared to do reconstruction.
Okay. Yeah, I think most everyone in the audience said they would do a formal SL reconstruction. Now, in this case, then it would be, oh, that's not plain, but pretty much in Garcia Elias's classification and staging, which I think is quite helpful. This would be the reducible, SL is not repairable, no arthritis, and that's just kind of showing what your scaphoid shift test, what you're trying to do in that patient. This is what it would look like arthroscopically. What do you do in this patient population? And so before we get to Kevin's talk on how he prefers to reconstruct the SL, probably a big source of controversy is how do you fix or reconstruct an SL? So let's ask this question before we get to Kevin's talk. And maybe while you guys are answering this question, I'll just go through the panelists. Doug, how do you like?
I didn't have a question 12.
Oh, okay. Well, question 12 was, how would you reconstruct your SL? And the question choices I could think of was like the 3LT, the so-called modified Bernelli, the now popular anatomic front and back, the ANAFAB, 360 SL reconstruction, some sort of central axis reconstruction, or an all dorsal reconstruction. So I'm just curious, going down our panelists, how you like to reconstruct these. Jeff, I saw that you're on. How do you like to reconstruct your SL?
Thanks, Peter. So I think in the past, I would have said the Garcia Elias triligament tenodesis, but I've been convinced, and I think Tom Fisher's on the call, so I would tip my hat to him. I'm convinced, especially with what you showed on the plain film and then confirmed on MRI, that dorsal subluxation of the scaphoid. I don't think the triligament tenodesis or Bernelli gets it, and I think then I would do the front and back.
Got it. Dr. Fisher, any thoughts?
I still prefer the Bernelli. It's like the ACL of the wrist. It's modified, obviously. Nothing goes across to the radius, but you got to kind of go with what you think's the most unstable. But I do like the fact that you prop up the scaphoid on the far end, because I think the STT ligament is deficient, as what Bernelli first talked about, and that's how he devised his reconstruction, to basically stabilize both ends. And I think that the real key was your CT scan with that scaphoid sticking out the back. And to me, the scapholunate ligament restrains the scaphoid from its dorsal migration by hooking it to the lunate, which is in a very deep cavity and doesn't migrate dorsally. So when you reconnect those two, the scaphoid sits in that shallow skating pond of a scaphoid fossa, and the lunate sits in a nice deep trough. So the lunate needs to, or the scaphoid needs to be restrained from dorsal migration by the lunate. And that's where I think some sort of interosseous ligament repair is very helpful.
Got
Now,
it.
the anafab might be the best one for this particular one because that giant gap you see on it.
Got it. And Dr. Hanel, did you have any comments before we move on?
No, I agree with Tom. One thing that I still use Bernelli's, and maybe it's just because I'm older and I've been using them for a while. But the one thing that I found very helpful is to using an ACL guide to pass tendon sutures through the scaphoid. And I found it very helpful. One thing that I learned from Tom was making sure that exit point, if you're going to do something like that, is really up proximal and dorsal to the scaphoid, so that as you bring it down, you will reduce that dorsal subluxation.
Got it. Great. Thank you. All right, Kev, let's see how you would do it. I'm gonna stop sharing here.
All right. So I have to thank Dr. Fisher and Dr. Hanel for the introduction of my talk, because I'm just going to basically echo and reinforce with some of the diagrams of how I approach these, and often, you know, as is expected, as Dr. Hanel was my fellowship mentor, I'm following his lead here. So, you know, what we assume we know about scapholunate instability is that, you know, the scapholunate interosseous ligament is the primary stabilizer for the scapholunate joint, but we also know that sectioning of this ligament in isolation does not result in acute instability. You're not going to see the diastasis or the rotatory subluxation acutely, as was diagrammed on that case that Dr. Reed just showed. And there are important secondary stabilizers of the scapholunate articulation, including the dorsal intercarpal ligament, the scaphotrapezoid ligament, and the long radiolunate ligament. You can see as these structures are overloaded because of the failure of the scapholunate interosseous ligament, then they may become attenuated, and then you might see these typical findings of scapholunate diastasis, and then the rotatory stabilization with that dorsal subluxation of the proximal pole of the scaphoid relative to the scaphoid facet on the lateral view there. So scapholunate reconstruction, there are many described options. Some have already been mentioned. There's no clear-cut best option, and a lot of it is going to come down to what's best in your hands, because what's best in your hands may not be what's best in someone else's hands. There are a significant amount of variables and outcomes that can be related to your surgical technique and your comfort level with the surgical technique. But patient selection and patient factors are very important as well. And I clearly remember sitting in the Harborview hand clinic one day trying to sell Dr. Hanel on a scapholunate ligament reconstruction on a firefighter. And he said that a soft tissue procedure would never work for someone with that type of physical demand, and that a bony procedure may be more appropriate. So you do need to take each individual case as an individual and figure out what their needs are. Chronicity of the injury and the overall soft tissue quality are also going to play a role in what your options are for these patients. In general, and these are pictures that I stole somehow from Dr. Bernelli's talk. So these are not my pictures, hence the Italian language here. In general, the scapholunate ligament is a relatively lax structure, and it must allow some degree of independent rotation between the scaphoid and the lunate during normal wrist mechanics. And scapholunate true dissociation is only possible if the rotatory subluxation occurs, and that occurs only when the ligament that Dr. Fisher mentioned, the volar scaphotrapezoid ligament, fails. If that volar sling remains intact, then you're not going to get enough flexion of the scaphoid to result in the dorsal subluxation. So there is a large component or a large body of evidence that controlling the scaphoid flexion by reinforcing that volar ligament is very important. So the scaphoid trapezoid ligament, again, relatively overlooked. It is a thickened portion of the deep surface of the FCR tendon sheath. And then Dr. Bernelli thought that this was the key component of rotatory stability for the scapholunate joint, and that any attempt at reconstruction or repair that did not address this was doomed to fail. And if you look at his, initial described technique for his procedure, that's essentially all he's doing is using a portion of an FCR tendon distally based through a relatively transverse tunnel in the distal scaphoid, and then attaching that to the dorsal rim of the radius. And so, this doesn't address the scapholunate ligament at all. It is purely an effort to control the scaphoid flexion. And he wasn't so worried about the so-called diastasis. He wanted to put that scaphoid back where it needed to belong. Bony procedures can also, really control the scaphoid, but these are going to have a more significant impact on wrist mechanics and a more significant impact on wrist range of motion. So as a primary procedure, I think, unless you have a patient with very specific demands, STT fusion or capitolunate fusion or even a four-corner fusion may not be the best option. Dorsally based soft tissue procedures have been described. Some of them are listed here using capsular tissue or the dorsal intercarpal ligament, as Dr. Ree showed, as an augmentation to his SL repair on his prior discussion. And a lot of these outcomes weren't great. And this may be related to the relative weak dorsal capsular tissue that can stretch out and fail over time. And as Dr. Bernelli pointed out, it's harder to pull a scaphoid into extension rather than to push it. So another reason why a volar component of this is really important. Now you see these marketed techniques using an augmented repair with a very stout material that may be more successful in pulling the scaphoid up into flexion. But there's some concern even with these techniques described here with the size of the holes that need to be drilled in the proximal scaphoid and the lunate. There was a question by a participant during the last talk about AVN of the lunate from all the K-wires in there. And if you're going to put these 3 or 3.5 millimeter drill holes in the scaphoid or in the lunate, that certainly could cause problems, fracture, and perhaps even AVN. So I do like this modification of the Bernelli procedure that Dr. Garcia Elias described here in 2006, his triligament tenodesis. And this is a really excellent article if you have not had the opportunity to read it, because it's a great review of the mechanics and the questions that you need to answer in order to find the appropriate treatment algorithm for these patients. And so he really wants these injuries to be staged, and he has these 5 questions. This is very similar to a slide that Dr. Ree showed prior to this presentation. And by answering all of these questions, which are yes or no questions, you can grade these or stage the condition as a partial scapholunate ligament injury, a complete but repairable injury. So that's oftentimes within 6 weeks of injury, as Dr. Grossman suggested. A complete but non-repairable scapholunate ligament injury. So perhaps more like the case that Dr. Ree presented just before I began this talk. A complete non-repairable with static deformity, but is reducible. So you're still getting at this relatively early. And then as it lasts longer, now you have an irreducible deformity, and even further with cartilage degeneration across the radiocarpal or midcarpal joints. And so, I think what we're really looking for is these stage 3 and stage 4, where you have complete but flexible deformities that are easily to reduce. Stage 1 and 2, these may be more appropriate for a variety of different primary repair or augmented repair techniques. And stage 5 and stage 6, I think we're pushing ourselves more into salvage procedures. So we're going to focus on these stage 3 and stage 4 here. And this is incorporating the principles that Dr. Bernelli established using that distally based FCR tendon pedicle to help reinforce the volar ST ligament. Here, the trajectory of the tunnel is a little bit more oblique and less transverse, exiting dorsally here, as Dr. Hannell suggested, where then you can bring that across the scapholunate joint and secure it with an anchor. You create a trough here dorsally in the lunate down to bone. So hopefully you have better tendon or ligament now healing to the bone. And rather than crossing the radiocarpal joint, as Dr. Bernelli originally described, this ligament is passed through the dorsal radiocarpal ligament and then passed upon itself. And so we've skipped, this is all the different steps here. So we're not crossing the dorsal radiocarpal ligament, which will improve our wrist flexion. Here we can see one of my cases the FCR tendon coming across, secured to the lunate. I had an anchor in the scaphoid as well, just as another point of fixation. And here is the FCR tendon graft coming through our dorsal radiocarpal ligament before we fold it back upon itself. And perhaps this has been mentioned. I have not had the opportunity to do this in a patient. I've done it in a cadaver lab, and I think there are certain advantages to this. In the beginning of the talk, we mentioned some of the other structures, and this anafab front and back reconstruction that was published last year with some promising early results also reconstructs this long radiolunate ligament to help control lunate rotation as well. So the take-home messages for these scapholunate ligament injuries is that this is the result, or the instability is the result with a failure of the primary and secondary structures. Correction of the scaphoid flexion is most likely related to good patient outcomes with all your soft tissue reconstruction options. So you need to make sure that you address your scaphoid flexion. And then the outcome of soft tissue reconstruction is very dependent on your patient selection and your surgical techniques. Thanks.
Kevin, thanks a lot. That was very good, helpful tips. There's a lot of ways that you can reconstruct these, and I think bottom line, it's I think what works best in your hands and what you feel like is a procedure that fits with your logic for how you should reconstruct these. And I did exactly what you had mentioned, Kevin. I did the triligament tenodesis, which I don't do as much anymore, just because I've moved to doing more of a central axis type of reconstruction that was that Mark Ross has described, that goes across the SL and LT and then reconstructs the DIC as well. But in this patient, I had done the 3LT, and before I show you the outcome of that, do you guys add any adjuncts to this type of reconstruction? For instance, doing a PIN neurectomy, because in case they have chronic pain, or adding on top of it like a capsulodesis, or putting a suture across to reconstruct the DCSS that I mentioned before. Do you guys do anything else at the time of your reconstruction?
I'll take it first here, and then we can see what the other audience or participants or mentors have to say. You know, I think there's, with every dorsal approach, I think the PIN neurectomy is sort of, you know, easy pickings there. I don't think there's much harm in doing that, and you know, perhaps you do partially denervate the wrist and minimize the symptoms of pain that these patients might experience post-operatively. And then with those suture limbs that I showed, you know, and similar to what you mentioned earlier, I do then bring those sutures up through the dorsal capsule and just sort of tie everything else back down in addition to the ligament reconstruction proper.
Great.
Peter, can I make a comment? Well,
Yes.
I get this feeling that Tom Fisher's breathing down my neck, but aside from that, he does have some great points though to make. Okay, so I asked 3 questions. Did you injure your wrist before? Did you hurt your wrist before? Have you ever had any wrist problems before? Because it's fairly uncommon for patients to present with an acute scapholunate tear, unless you're you know, taking care of young military patients. The average patient that comes in has probably a subacute or chronic scapholunate problem. And the classification of the original one by Lavernia, Telesnik, and Cohen, the 3 components: the adequate ligament, is there arthritis, and is it reducible? And the variation that Kevin mentioned by Garcia Elias, is it reducible? You don't know until you're in there. So the other point is that you always have to have a plan B and talk with the patient about that. What is plan B going to be if there's arthritis in there, if it's not reducible? What type of salvage would you like us to do?
Yeah, that's a good point. I think unfortunately we've probably all been in a situation like that where you weren't quite expecting things, even if on X-ray it looked, you know, that no, you know, slack changes, and you go in to reconstruct it. And that goes to, I think Dr. Hanel had a question about if this was longer. So let's say, yeah, I don't remember I don't ever remember injuring my wrists, and they have, static instability. And they say, well, maybe like a year or two ago, perhaps. Would that change your mind in even from the get-go? I mean, would you then go in saying, hey, I'm going to try to reduce it, but if I can't, then I'm going to do this? Or would you just say, you know what, I'm just going to go straight to, whatever, I guess I don't want to really quite say salvage, but kind of like like an STT fusion, SC fusion, or something like that? The timing of how long it's been, would you just say, I'm just going to go to some different route than ligament reconstruction? Or would you still, if there's no arthritis on x-ray, just say you're going to try if you can reduce it? And
I'll answer that. I would say that it's interesting because on the surface, this seems like a pretty straightforward webinar, but there's not uniform agreement about how to manage perilunates, or for example, and this one is even more controversial, I would say. There are some who would say if the results are so unpredictable for scapholunate reconstructions that fusion or a salvage procedure is the right answer.
yeah, I had a patient once who was one of these like guys who's out deployed, who doesn't even wear the uniform. He's kind of just like got a big goatee, and one of those type of patients. And he said, "Hey, he's like, hey doc, I just want something reliable." And I said, "Well, I'm gonna give you an SC fusion then." And he's like, "Okay." And he did awesome with that. So yeah, I think there's a lot of controversy. It's a lot of patient factors too. Which I'm going to skip this question because it's going to lead to my next one. So I did the 3LT, took the pins out. I usually take them out anywhere from 8 to 12 weeks, 8 being a minimum. So that's why I bury them. And it's not the best lateral, but I think that his lunate, the capitate is fairly collinear, and I don't really see too much recurrence of a static carpal instability. And his motion was actually pretty good. He actually really surprised me. I laid crepe again that he would be stiff, but boy, he did a great job. So my question is, I remember many years ago, I was a fellow, or maybe it was my first year in practice. I went to a pre-course at the ASSH in Boston, and it was awesome. Just all the experts on SL reconstruction, and everyone agreed that if you reconstruct an SL, patients should not go back to any loading of the wrist and extension. If you do, don't ever get x-rays. So I guess my question is, if you have a patient who you're going to say, I'm going to reconstruct your SL, do you give them any lifelong restrictions, or do you just say, you know what, just get after it? You may get some diastasis again, but it's not a big deal. Kevin, what are your thoughts?
I don't know that I've ever formally given restrictions like that to patients, and nor do I think they would ever pay attention to any of the restrictions if I were to give it to them. I have seen reconstructions come back with x-rays that look great, and patients that are incredibly happy and have great motion. So, the whole idea of not getting x-rays, because what are you going to do with an x-ray that looks really bad and you've got a happy patient? And the answer is you're going to do nothing until, the patient's smile is no longer there. But I think it's important to say that to many of these patients, as you're counseling them before their index procedure, is, this is not going to restore the wrist you had before your injury. This is not going, and this may not be the last procedure that you have for your wrist. We're going to try to give you the best wrist we can for as long as we can, but this may not be the end game for you.
Yeah, I think that's a good point. Sometimes it's like the irony in talking with counseling patients, because with these subacute SLs that I feel like I can reconstruct. I tell the patient, look, if we don't see on your X-ray you have this carpal collapse, malalignment, instability pattern, we're going to reconstruct this. Otherwise, you'll get this predictable arthritis. I don't know if you're going to be symptomatic if you get arthritis, but we're going to fix it. And then, and I will say that I've definitely had patients I've reconstructed that I take the pins out and they come back in 6 months, and they've dropped back into some sort of instability, static instability. And I say, well, we can can expect that it may stretch out a little bit. And they say, well, didn't you do the surgery to correct all the alignment? And now like you're okay with that? And I'm sure you guys have all noticed that too, where you take the pins out and things fall apart. Well, I guess I shouldn't say fall apart. You kind of lose your reduction and your
Turns out
alignment.
that the real reason you did that surgery was to do the PIN neurectomy.
Yeah, yeah. Or the fact that, you know, if you, like you said, if you do the 3LT, maybe it's just that you have a new buttress, like a soft tissue STT stabilization, or, you know, now, like Dr. Fisher said, you're not having the proximal pole, you know, pop out and causing the, you know, wear on the dorsum of the scaphoid fossa. I'm not really quite sure what it is, but even though that happens, they kind of almost universally their pain and symptoms go away. Any final thoughts about that from the panelists? If any sage
Yeah.
wisdom?
Well, I would just say that, as you alluded to, scapholunate gap is almost inevitable, regardless of what you do, unless you fuse the scapholunate interval, which is not easy to do. You're going to get a little bit of a gap. As long as it doesn't rotate, the patients tend to do pretty well.
Yeah, no, I think that's a good point. It's I could recall I take these pins out wide awake, and I had done a 3LT, probably my last one at the time, and my fellow took the pins out. We got X-ray, and he says, "Oh man, it's completely falling apart." I was like, patient's awake. Is everything okay? Anyhow, this has been a great webinar, and like Dr. Cassidy had said, we're really just scratching the surface, and this probably requires a full course on SL and a carpal instability. But if you could take anything away, I would just say that you know, the Mayfield classification, which is not the best, but it's the most well-known mechanistic explanation of how these happen. And so I think that scapholunate injuries exist on the spectrum towards a perilunate injury and a lunate dislocation, but don't hang your hat on the fact that, well, it can never have an SL tear if you have a transcaphoid perilunate, or the SL short radiolunate should always be intact. There can always be variants, so just be cognizant of that. And if you're going to reconstruct any intrinsic carpal ligaments, you got to know carpal anatomy, kinematics in the normal and then the pathologic wrist. Thank you so much to the faculty members. I know you spend a lot of time on those talks, and they were very informative, and I cannot thank the panelists enough. That I mean, these are the people that you know are sit on a high pedestal for me, and so I thank you so much for giving your insights on all of these. There is more to come, so everyone that's joining in, the 155 of you, and those that will be watching, there are tons of upcoming courses, so please join us. Next being scaphoid fractures on February 11th. And you can certainly access these again if you want to hear our banter again. Just give us a couple of days to get those uploaded onto YouTube. Thank you very much. Be safe.